Okay, good evening, everybody, and thank you very much for joining us in what is the third webinar of our 2021 series. My name is Paul Reed, and I'm the General Manager at the Institute in Sport, Exercise and Health here in London. The Institute provides excellence in sports performance, injury prevention and management whilst bridging the gap between elite and amateur sport. We are also a centre of excellence for exercise prescription for the improvement of population health. If you want to find out some more information about our clinical services, or if you want to view the recordings for any of the previous webinars, please visit our website at www.ich.co.uk. So on to the business of tonight, where the focus is on all things shoulder injuries, assessment and monitoring. And I'm delighted to be joined by a team of experts who combined have got years of experience in elite sport and more specifically with athletic populations who frequently experience shoulder injuries. The format for the webinar tonight, we're going to have three 15-minute presentations for you, and then this will be followed by an interactive Q&A session during the last part. Throughout, you'll see there's a chat box on your right-hand side. Please feel free to post your questions in there, and then at the end, we'll attempt to answer as many of these as we can. Please also feel free to share the content on social media. We want you to tweet as much as you can, because this will enable us to achieve a broader reach, and I'm sure many others who could not attend tonight will benefit from the information in the talk, so please feel free to tweet as you go. So enough from me. Our first speaker this evening is Professor Mike Loosemore. Mike is a consultant, is a sport and exercise medicine consultant here at the Institute, and is also a lead sports physician for the English Institute of Sport. He is currently the Chief Medical Officer for GB Boxing and GB Snow Sports, and he has travelled extensively with national squads accompanying teams to 4 Olympics and 5 Commonwealth Games, World and European Championships, so he's got quite a CV. Professor Loosemore is also active in various fields in terms of sport and exercise medicine research, so we're looking forward to some really unique insights from some of his experiences and work to date. So without further ado, I'll hand over to Mike.
Thanks very much, Paul. And it's very good to be here this evening. It's particularly good to be presenting with Gus Morrison and Ben Ashworth. I currently work with Gus, and I've worked with Ben Ashworth in the distant past, but I've kept in touch with him and kept in touch with his research, and he's an exceptional, they're both exceptional physiotherapists, particularly around the shoulder. So my presentation, I can't see. Yeah, well, that makes more sense. So I've put the picture up just to remind me that the shoulder is an extremely mobile joint and can get into lots of different positions. This is really useful, so we can put our shoulders where we want, but it also means that it is prone to injury. I was asked to talk about common shoulder injuries today in 15 minutes, so I thought I'd talk about the acromioclavicular joint, dislocations, slap lesions, bicep injuries, and GERD. What I'm not going to talk about is impingement, because impingement is not a diagnosis, it is a symptom, and non-specific shoulder pain, which I think is a fairly meaningless description of shoulder pain. Doesn't really help anybody. So starting off with acromioclavicular joint sprain. Usually happens when you land on the tip of your shoulder. We see it frequently in cyclists and rugby players. Also, you can see that Boris Johnson could have got a nasty acromioclavicular joint sprain here as he took out this small child. It often presents with a step in the shoulder joint, or just, well, it usually presents with just pain at the acromioclavicular joint. Obviously, this is a more extreme sprain of the acromioclavicular joint and shows a step in the skin. There are various types of ACL sprain that we see. Obviously, the commonest are the type 1, type 2, and type 3. And all of these can respond well to physiotherapy, as can sometimes type 5. Type 4 and type 6 often need surgery. However, in elite athletes, we often do repair these or get these repaired surgically. And it really depends on whether the athlete can cope with the disruption of the joints or disruption of the ligaments. Sometimes it's not a problem, but often it is an issue with them, and they do require a surgical intervention to repair the position of the clavicle so that the shoulder functions properly. Talk a bit about dislocated shoulders. So shoulders dislocate usually when they're in a very unstable position. So this is with your shoulder abducted and externally rotated, which you can see in this quarterback who's trying to throw a ball and is getting tackled at the same time. When athletes dislocate their shoulders, they will often hang on to the arm and support the arm, and you will see a step in the shoulder where the head of the humerus has come out, and there is that very clean step. You can see it better on this next photograph, where you can see this young man has clearly dislocated his shoulder on the right-hand side. Now, dislocated shoulders can obviously be put back in, but the long-term sequelae is really what we deal with. This is a CT scan looking from behind, and you can see the edge of the glenoid hitting the head of the humerus. And when that happens, you can get a Hill-Sachs lesion in the humerus, which is an indentation into the humeral head. And the problem with that is that if you continue doing it, you can get a large lesion within the head of the humerus, which again needs a surgical repair. The other problem is the Bankart lesion. This is where, when you dislocate your shoulder, particularly an anterior dislocation, which is what we're talking about here, posterior and inferior are much rarer. But an anterior dislocation, you can tear away the labrum from the glenoid, and this can make the shoulder unstable. And again, that may end up with a surgical repair of the shoulder. So, and this tends to be the recurrent instability of the shoulder then becomes an issue. And it's certainly in younger athletes where you are more concerned about needing an early repair. If somebody dislocates their shoulder under the age of 20, they're almost certainly going to need a surgical repair. The older you get, the less likely that will be required. And when people get much older, then often they don't need a repair, and this can be stabilized by physiotherapy. What we do see a lot of is slap lesions or superior labral tears from anterior to posterior. These can be traumatic with shoulder dislocations, but often the ones we see are in throwing athletes where the condition is more chronic. So we can see it in baseball pitchers that always get their arms into nice positions. or it can be tennis players, javelin throwers, and in boxers. I see quite a few of these in the boxing community. So what happens is you're really pulling on your biceps tendon, and we can see in this picture of the glenoid, the biceps tendon at the top, pulling away the glenoid labrum. And that can make, again, if you pull away the glenoid labrum, you can make the shoulder unstable. I'm sure the physios will tell you that most of these can be looked after with strength and conditioning. This is an MRI scan with contrast into the joint, clearly showing the area of the labral tear. So, as I said, we used to repair a lot more of these than we do now. And we're finding now that with a lot of the slap lesions, they do extremely well with physical therapy and with strength and conditioning work. And I've got several athletes with quite severe slap lesions, which are quite extensive, where they have not required a surgical intervention and have done extremely well with physiotherapy. As I said, the shoulder is a very mobile joint, and so most of the stability comes from the muscular action around the shoulder joint. And it's the imbalance of that muscular action that causes most of the problems within the shoulder joint. So I'll talk about some biceps injuries. Obviously, we see rupture of the long head of biceps as it passes through the bicipital groove. And the question is, do you need to repair that, or do you not need to repair that? Well, initially, when it tears, the muscle bunches up and you get the so-called Popeye muscle, where the long head has gone and the muscle is gathered up distally in the arm. Whether you need to repair it or not, I guess depends on the level of the athlete, but most athletes who are throwing athletes or need their arms to produce power will have that repaired, but in the older population, I don't think either of these pictures are of athletes will require do not require repair, and you still have good strength in the arm, and a lot of people don't even notice that the long head has gone if they're not an athlete. But for me, the bigger concern in biceps injuries is at the other end of the biceps, at the distal end, where you, and I see this particularly in boxers, where you get edema and partial tearing or even complete rupture of the distal end of the biceps. Obviously, this is a really big problem, particularly for boxers, because they will lose all the power that they have in the arm if that ruptures. And we keep a very close eye on those, and if they do rupture or even partially tear, we do get them repaired as quickly as possible. And we have had some excellent results from those bicep repairs. And again, when you see that, and you've got a rupture that has come from the distal end, the biceps gets pulled up the arm, and you don't get that bicep lower down, you get it higher up as the muscle bunches up. So good. Finally, I thought I'd talk about glenohumeral internal rotation deficit, which we do see a lot of. And this again is seen in throwers, is well described in pitchers in American baseball. And this is a really nice picture of the sort of position you can get your arm in if you try hard and practice a lot. And that doesn't matter that you can get your arm that far back, and that doesn't necessarily mean that you've got good. You expect rotation, internal and external rotation, of around about 180 degrees. And if you're a good pitcher like that, then you will be able to rotate your arm. You get greater external rotation, but less internal rotation. In good, what you find is that you actually have limited external to internal rotation with limited internal rotation. And this is because you get, with the continual stretching of the anterior part of the capsule, you get a lax anterior capsule with a tight posterior capsule. And the problem with this is that not that the posterior capsule is painful, but it changes the dynamics of the movement of the humeral head on the glenoid, which causes the head to impinge, which causes pain. And again, this is something that would be changed by good physiotherapy and good strength and conditioning, as most shoulder injuries can. So that's the end of my talk on shoulder injuries. And as I said, I haven't talked about impingement, and I haven't talked about non-specific shoulder pain, because one's just a symptom and the other one, I don't really know what it means. Thank you.
Thanks very much, Mike. Very insightful presentation and great overview of shoulder injuries. I think it really sets up the context nicely. Just a reminder that on the right-hand side of your screen, you'll see the chat box. So please post your questions throughout, and we'll address those at the end during the Q&A. So we'll move on to our next speaker, which is Fergus Morrison, or otherwise known to us affectionately as Gus. So Gus is a senior physiotherapist at the Institute of Sport, Exercise and Health, where he treats both elite and amateur athletes. He's also worked at Trim Rugby Club as the head physiotherapist during seasons in which they achieved promotion to the London Premier Division. Gus has a master's degree in sport and exercise medicine from UCL and is also an accredited strength and conditioning coach with the UK Strength and Conditioning Association. Gus has pioneered the development of the assessment unit, the shoulder assessment unit at the Institute, and has also published research in this area. So I'm really looking forward to Gus's presentation, which will give you a nice slide overview of some of the work that's been developed here at the Institute. Over to you, Gus.
Thanks, Paul. As Paul said, my presentation is essentially going to look at shoulder assessment and monitoring, specifically at the ISCH. So looking at what we are assessing and how we assess it. So Mike talked about the structural components of shoulder pain, whereas the Institute shoulder pathway is adding to that and looking at the functional components. These functional components essentially can be broken down into these three areas. So if an athlete has appropriate mobility to access optimal positions, are they strong enough to produce force? Not only can they produce force, but are they wired up to react in the right time, right place, right speed, including their rate of force development to protect their joints? Are they able to transfer force with efficiency created by optimal kinetic chain sequencing, which is basically summed up in those three separate components. So the rationale for testing mobility is to establish the athlete's ability to access optimal positions and their ability to dissipate forces over a number of different structures through the kinetic chain. For this reason, we test mobility of both local and global structures. So on from what Mike was talking about, looking at total range of movement, the arc of rotation is particularly important in throwing sports as athletes transition from high degrees of external rotation in the late cocking phase to end range internal rotation in the follow through. Injury is more likely in overhead athletes with internal rotation deficit, but is also increased. Risk is increased in collision sports such as rugby in players who have an internal rotation deficit. So total range of movement is the arc of rotation from end range external to internal rotation, and we test that, as you can see, actively in a supine position. When considering overhead athletes, the optimal upper limb and thoracic movement improves force distribution, coordination, and stability, and compensatory MSK injuries and improving performance outcomes. In throwing sports, this relates to force generation, as well as maximal and sport-specific glenohumeral joint range of motion. As an example, decreased shoulder flexion would require the athlete to compensate by extending their lumbar spine when pressing overhead. We use a shoulder to wall test to assess flexion using an inclinometer. So the long sitting position here essentially prevents any compensation through the lumbar spine to give a true reflection of shoulder range in isolation. So the dowel rod is used to standardize the hand position. So when we retest at a later date, we know we're retesting the same structures. Restrictions in mobility of the thoracic spine can impair functioning of anatomically related regions such as the shoulder, and this can predispose it to pain or injury. Individuals with restricted thoracic spine mobility tend to experience a decrease in shoulder function and complain of symptoms of shoulder impingement and pain. Throwing and combat sports such as javelin or boxing require adequate thoracic rotation to transfer force generated from the lower limb to the shoulder girdle. So thoracic rotation deficits can cause a disconnect between the scapula and the humerus, as the arm is required to drop into excessive horizontal abduction when the thoracic spine stops rotating. So this test is a lumbar locked rotation test and allows thoracic rotation to be reliably tested. The active range is tested in this position demonstrated, preventing the lumbar spine from rotating. The final components of the mobility battery are internal rotation movement at the hip, and that's essentially because decreased hip internal rotation of the stride leg is significantly associated with elbow or shoulder pain incidents in throwing sports. This highlights the importance of the ability to transfer force from the lower limb to the upper limb and distribute this force over a number of structures through the kinetic chain. So hip internal rotation is tested in sitting and is measured actively. We also test hip extension, and that is because forces at the shoulder are greater in athletes and patients who are compensating for injuries or range of movement restrictions at some distance from the shoulder. So deficits in hip extension may be related in baseball players with history of shoulder injuries. And we simply just use a modified Thomas test to measure the range of movement into hip extension. So in terms of the 3 pods we were looking at, the second one is strength, and I've used the term strength in this presentation, although it's a bit of an umbrella term and often creates a bit of confusion. For the purposes of this webinar, it will essentially cover a broad spectrum of force production, whether that be the muscle's ability to sustain force, the peak force, or the rate of force it can produce. Ultimately, we want to know if the athlete is able to produce and absorb the forces that they're required to for their sport. So the first component of this is a posterior shoulder endurance test. Arm fatigue is frequently being associated with upper extremity injury and pain in a variety of throwing sports, and changes in muscle stiffness are frequently associated with repetitive eccentric exercise, which you could classify as throwing. We use the posterior shoulder endurance test to test the patient's ability to sustain force over a prolonged period. So the weight used in the hand there is 2% of their body weight, and they're asked to hold their arm parallel to the floor as long as they can. We just use the box there, so if the weight touches the box, that would be the end of the test, and we measure the time with a stopwatch. Looking more globally, we look at the endurance of the shoulder girdle, and that's basically looking at pushing and pulling movements. During these movements, the major protractors and retractors of the scapula must be recruited. So changes in scapular movement and subacromial pain are associated with significant weaknesses of the protractors and retractors of the shoulder girdle. So we ask the patients first to do as many push-ups as they can before doing inverted rows to failure. This then creates a push-to-pull ratio where we use the patient's body weight and a percentage of that to create a ratio, and we can look at an athlete's balance through the anterior and posterior chain. One area that has probably got more research than pretty much anywhere else in the test batch, peak force of the rotator cuff. For example, decreased internal and external rotation strength with injury in base, other throwing sports, where higher strength scores of proximal muscles are associated with decreased injury risk on a frequent basis. There are a variety of testing positions which vary among the paper you read, but the prone position allows the patient to remain stable in order to give them the best chance of producing as much force as they can. Internal rotation will typically produce more force than external rotation, but athletes with ratios closer to 1-to-1 appear to be more robust. So I'm sure Ben will go into more detail on this, but here we look at long lever peak force as well as rate of force development. So we know that injury risk is significantly increased in rugby players during tackling and defensive drills when they're required to cope with higher speeds, higher collision forces, and unstable positions. And this would be a good example would be a long lever arm tackle. A long lever isometric test may therefore be an appropriate means to replicate the shoulder muscle contraction required in the tackle position. Based on its correspondence to the demand on the tackle and associated mechanisms of injury, it's a suitable test with good field validity. The athletic shoulder test is tested in 3 positions, and the Y position is being demonstrated here. The patient is asked to push as hard and as fast as they can into the force platform for 3 seconds. You can see on the tablet it produces a force time curve, so we can explore how much force they can produce, but also how quickly that force can be applied, which is shown by a steep upward curve in the graph. It's well and good being strong, but if it takes a long time to build up to their peak force, it's not particularly useful in the majority of sporting situations. On this test, we essentially want to assess the athlete's ability to rapidly produce and absorb force from both a performance and a health perspective. For example, there is a large body of evidence to show that rate of force development lags behind peak force in ACL rehab and recovery, which is highlighted with lots of research on jump testing. We're basically borrowing that principle and applying it to the upper limb for a health perspective, and from a performance perspective, increased upper body power on a plyometric push-up, which is being demonstrated here, is associated with superior tackling ability in rugby. Provided the patient capable of performing this task. We do this on a dual force plate system. This tells us how they distribute force between their injured and non-injured limb, and to give an indication of how much force they can produce and absorb, as well as their strategy to do so. Taking the whole chain into consideration means that we assess the lower limb, the shoulder, in isolation. This is essentially because more than half of the force utilized in a tennis serve is supplied by the lower extremity and the lumbopelvic hip complex, while high levels of low body power is associated with tackling ability in professional rugby league players. This suggests that even if there are adequate levels of mobility, strength, and coordination at the shoulder locally, if there is minimal force coming from the lower limb, the demands of sport are simply too great for the shoulder to deal with independently, and therefore makes it more likely to overload and reach the point of structural failure. So we assess lower body power using the counter movement jump. Again, this is on dual force platforms, and the benefit is to compare right to left, as well as comparing what is expected of someone from a similar background or sport. So the final component of the test battery of that triad of pods looks at a patient's control and coordination. Here we want to assess, are they wired up to react in mechanically advantageous positions, have the awareness of vulnerable positions, as well as being able to integrate the individualized components of mobility and force production in coordinated movement. The first component of coordination is so athletically active individuals who have chronic traumatic shoulder instability have significant deficits in their proprioception. So joint position sense in the end range position is reduced following a fatiguing task. If the mechanoreceptors are unable to report the shoulder position in the outer stretch position, there's potential for the anterior structures to become stressed before any compensatory muscle contraction can take place. So is the athlete aware of where their arm is? If their arm is too far behind them or in an abducted, externally rotated position, they're potentially vulnerable and they're not aware that they're in that position. So we test this in side lying. Here I ask the patient to close their eyes before taking them to a fully abducted position. In the video now, he closes his arm and then he returns to that fully abducted position, and we measure the joint position again and calculate the error score. It should usually very accurate within a couple of degrees. The final component of the entire test battery together is a landmine press. So once we've established that the athlete has sufficient control, strength, and mobility in isolated tasks, we aim to integrate this to essentially assess how well they can coordinate these components via the kinetic chain. So for this, we use an Olympic bar and a landmine attachment and ask the athlete to throw the bar as hard as they can and record the velocity of the bar. So if we want to dig any deeper, we aggressively add load to the bar and observe the extent to which velocity decreases to form a power profile of the athlete in question. So here, if we wanted to gain some more information, we could put another 5 kilos on, measure the deficit in velocity. The heavier it is, the slower the bar will move. Repeat that a couple of times, which would provide us with a curve, and we could explore that to see if there's any obvious deficits, suggesting problems in the kinetic chain rather than in isolation. So that essentially sums up what we do as at the institute in the shoulder monitoring pathway. And then I think Ben's going to talk about the implications of what we do with this information.
Brilliant. I think it's given us a great overview of some options there that we can really get a thorough and comprehensive full body assessment of shoulder injury. So that's fantastic. So we'll move on to our final speaker then. Just before we do, I'm seeing a lot of questions coming through, which is fantastic, but keep posting them on the right-hand side of your screen and we'll answer those once Ben has finished his talk. So last and by no means least, Ben Ashworth is our next speaker, and he is a consultant for teams and individuals and helps them solve shoulder problems. And he's been doing this for over 20 years. He is currently the director of performance at Sparta Prague Football Club and is a former first team physiotherapist at Arsenal FC. Ben's interest in shoulders developed from his time in professional rugby while he was at London Wasps, and this was accelerated through his work with British Judo and the British Judo team and the English Institute of Sport in the lead up to London 2012. Ben is currently working towards the completion of his PhD in the area of shoulder performance and monitoring, and he has published lots of research in this area. He's obviously widely known for the ASH test, which I'm sure we'll talk about in a second. And his work is being applied now worldwide in baseball, tennis, rugby, Olympic and collegiate programs. So really looking forward to this talk. And Ben, over to you.
Thanks very much, Paul. Yeah, real pleasure to be involved in this whole setup, and it's a delight to follow Professor Mike Loosemore and Gus Morrison as well. A really nice couple of presentations there to tee up mine. I'm just going to talk a bit about the application of testing within an elite sport environment, and try and give you a little bit of a flavour of some of the stuff that perhaps you won't read in the research, some of the things that perhaps are applied by elite organisations that currently sit as just unpublished work. Okay. So first of all, a little bit of context around what we're going to do. Then we're going to look at measuring the things that matter. I'm going to talk you through some of the research that I've been involved in, and then the applications, working with some really sharp people who've taken some of the ideas and put them into practice to give us some information. And that's really it around the context. Essentially, we want to try and identify trainable deficits within our individuals. And there are going to be, low-tech and high-tech options around how we do that. Sometimes when you look for the research and the answers in the research, there aren't any there. So you have to sometimes draw your own map. And that's essentially what we're looking at here tonight. So in terms of context, I wrote a piece which you can follow in the Informed Performance digital magazine release recently about this complex web of determinants, which in this example, originally the paper was from Natalie Bittencourt looking at ACL injuries. But in this particular example, what factors interact to result in an overuse injury, particularly say in an overhead throwing athlete like a baseball athlete. And as you can see, it's a hugely complex web, and the athlete state is going to vary, whether they adapt or whether they deteriorate along a season. But when I break it down into simple terms, what we can look at and what we're looking at with this monitoring process and this shoulder pathway is looking at the internal capacity of the individual that we're assessing. So in terms of things like mobility, which Gus talked about, and then also strength and force production. But we also then come across the external load. And we know from some of the more recent research in sports which use the shoulder, like handball, that when you have a massive increase in your load, over 60% from week to week, it doesn't really matter what your internal capacity is as an athlete. You're much more likely to get injured. When your external load spike is low, so 20% or below, I think, it doesn't really matter. Again, you're probably not going to have a higher increased risk of injury. But when it does matter, between those sort of 20 to 60% increases in your training loads or your match density or volume, it really does matter how strong you are and how mobile you are to make sure that you can meet the demands of your sport. So the context really is a few years back, and I've done a lot of monitoring in shoulders in judo, but I was put together with a really sharp team at Saracens Rugby Club, and they were looking to solve a shoulder problem. And the shoulder problem was people were getting to the end of a rehab pathway, passing all the tests, lifting heavy in the gym, bench pressing high loads, passing tests of short lever handheld dynamometry. And yet when they went out onto the pitch and did their return to play process, they broke down when they went into those long lever positions that Gus has already described. So What we looked at is this idea, and Gus has already shown you some of the ASH test stuff, but we created this force platform test looking at 3 positions. It's really important that it's a hard and fast, or fast and hard, I should say, is the coaching that you need. 3-second isometric test to try and maximize the rate and also the magnitude of force that you can produce. The eye test position is more stable, and then we take away that stability by putting the hand behind the back for the Y position. And this really looks at the strategy of how you generate force from the base of support and then deliver that through the arm. So instead of strapping someone into an isokinetic machine, which may be less transferable to the sporting action, we're not trying to constrain their trunk when they deliver force into the platform. So when we look at the ASH test and what we found with that early pilot work, we were looking at these force time curves. And my early work with sort of handheld dynamometry had looked at peak force. But the problem with peak force is it comes late in a 3-second trial. So if you give an athlete time, they can access peak force, even if they're under conditions of fatigue, or if they have pain, or if they're grumbling with a shoulder injury. But what we're really interested in are the meaningful actions of the sport. And the meaningful actions are protecting that joint. And those happen in the first 100 to 250 milliseconds. So what we look at is this steep attack phase in the ASH test to look at their rate of force development. And we're currently doing some background research into some rugby players and some baseball players to really identify what the best metrics to look at here. But obviously, for the purpose of this talk, just those rate metrics in that early phase are really key to understanding the full recovery or full potential of a shoulder to return to the chaos of throwing fast or even smashing someone in a tackle. And here's that kind of vulnerable position, that long lever vulnerable position where those athletes were breaking down. And that's the kind of problem that the group at Saracens were trying to solve. What we also found from that early work was that it mimics some of the ACL research and some of the hamstring research in that RFD, or rate of force development, returns later than peak force in rehab after surgery or rehab after shoulder injury. What was really interesting when we did some of that early pilot work as well was EMG showed that even though we're pressing in an anterior direction, there's a high activity in the posterior shoulder, both locally with regard to the posterior deltoid and the posterior cuff, but also in the mid trapezius. Peak force recovery also takes about 72 hours, which mimics some of the hamstring work that I did at Arsenal and some of the literature that's been published in that area. So, you know, if you play a game on a Saturday, then your peak force doesn't recover until the Tuesday. So then it informs programming, you know, trying sometimes to give athletes more recovery if their scores aren't back to normal by day 2 or by day 3. So what? You know, we found out that someone hasn't got the ability to produce force fast. So they might be, you know, strong athletes, if you like, but when you don't give them any time, we want to know, can they produce it enough to protect that joint? And here's some of the stuff from Paddy, the strength and conditioning coach, and Laura, the physiotherapist, who worked at the time at Saracens, and some ideas on restoring a sort of graded progression back to being able to create stiffness or also absorb forces fast at the shoulder to protect the joint. So first, a sort of self-initiated deceleration activity. And then secondly, a catch and release exercise. And to add high tariff to this exercise, you can ask the participant to close their eyes, just taking out some of that visual or other kind of feedback and focusing more on the joint position sense. And these are certainly kind of an extension of the work that Gus was talking about with that joint position sense in a more controlled environment. With the data that we got, obviously there are differences in size of player. And I think what I'm really keen on saying here is that peak force in isolation is not enough to look at a group of athletes. You need absolute force values. And in this case, with the original 18 players looked at in the Saracens study, 155 was the mean for that group. And you can see the distribution across that group, you know, some people up to around 270 newtons of force in that eye test position. But when we normalize that for body weight, what we see is there's a big difference with regard to the relative peak force in newtons per kilogram. And I think both of those values will stack up as being really interesting when we look at athletes who stay healthy and those who break down. Some work, as I said, then applying this test to other sports, and I worked with Chris McLeod at the LTA, he's the strength and conditioning coach there, and what they looked at with their group, and Gus was integral in collecting some of this data around their academy athletes, was looking at lower limb peak power using the CMJ, the Ash test for upper limb force production, a measure of shot power, and then looking at that against their injury background. And what we saw was that the kind of classic high lower limb peak power, high upper limb peak power resulted in, or was correlated or associated with a high shot power and a low injury background. The opposite in terms of the low and low. And then the really interesting group were the players who didn't produce enough force from the lower body, but had high upper body peak forces. And they tended to be the players that were described by the technical coaches as being very arm dominant in their tennis stroke. And that created this concept of this quadrant approach, which then has been since applied by some Major League Baseball teams after some discussions that we had. And so first of all, what they see is that, you know, Gus talked about the 50% of the force production for a high velocity throw comes from the lower body, somewhere around 51 to 54%. So if you look on the left quadrant there, you can see this idea that the high lower body force, low upper body force quadrant, they're producing high forces from the ground that their upper limb can't cope with. And then if you flip that around, you've got the low lower body force production, high upper body force. They don't access or generate or accumulate enough force from the ground, so they have to catch up by using too much force in the shoulder. And the shoulder really shouldn't be the area that's strengthened when we're looking at these kind of upper limb throwing sports. Most people will get faster velocity out of throwing or further distance out of throwing if they optimize their lower body force production. The quadrant on the right, what you can see there is a look at rate of force development versus peak force. And what we found when we looked at 92 pitchers in the Major League who'd thrown a fastball over the course of a year, we saw that the low quadrant, there was a high percentage of people in that group who were on the injury list. So there's definitely this idea that if we can program to change our athletes to high force producers and they can produce their force fast, they're going to lower their risk of injury. Although, of course, that's unpublished work at this stage and it needs to go through more rigorous scrutiny. The other really nice concept that I'm going to bring to you today, I think, is the idea of session cost. So not only what's your test score, but what happens when you test someone, put them through a normal process of training or a standardized or quantifiable load. So initially this idea was sort of taken and used in London Irish Rugby by Paula Timpson. And some recent conversations I've had with Joseph Coyne in MMA at the UFC Shanghai Institute, what he's done is looked at athletes before a session, looked at the Ash test, looked at then a striking or a grappling session, and then re-measured the Ash test immediately afterwards. And what he found was that those athletes who were above a cutoff before, so the strong group, didn't have too much deterioration with regard to force after the session. But those who were lower or below that cutoff point, they basically suffered more with regard to more variability between their trials after the session, a drop in peak force capacity, and definitely this difference in asymmetry, which was made worse when you looked at striking versus grappling, which tends to be more unilateral. So essentially, we've got a test here which is reliable, which when we then measure athletes after a session, we can tell whether they're coping with that last phase, which is often the phase where people break down when they're returning to play. So that's a lot about the force platform testing. The other testing around handheld dynamometry or fixed jig testing, like using a force frame, we're really interested in the force couples that we see. And this is a mock-up because I can't show you some of the data from baseball, but this is a mock-up of the force using a force frame of external versus internal rotation in prone over the 3 to 4 time points. So 3 time points in one season, beginning of preseason, end of preseason, and mid-season. And what we're trying to show here is this deterioration of external rotation force production on the right side throughout the season. And what you don't see really is much change in internal rotation force production. So in most throwing programs, what we need to do is look at external rotation and do something to make sure that that doesn't suffer throughout a competitive season. The balance, as Gus has already discussed there, should be somewhere ratio of around 0.9 to 1.1, ideally. But yeah, what we're trying to do there is look at the profile of the athlete in terms of anterior, posterior force production. But we're also looking then at the whole profile. So it's not just about anterior, posterior cuff. It's about, superior and inferior cuff working in synergy. So even those powerful global mobilizer muscles, when they work against each other in synergy, you create a stable joint. So that's the last real thing I wanted to talk to you about in terms of some applied work. And of course, I'm happy for anybody to contact me directly, but now it's time for some questions and answers. I'm really excited about the work that we're doing and where that's going to lead over the next coming years.
Brilliant. Thanks, Ben. Fantastic overview and some real applied insights. So for the interest of time, let's get straight into the questions. I've obviously been keeping a note throughout. What we'll do is probably got time to fire a couple of questions at each of you, and we'll probably work in chronological order from the talks, if that's okay. So first question for Professor Loosemore. There was a question that came in regarding shoulder injuries that don't respond well to physiotherapy in your experience. And also you mentioned slap lesions, and you said that you used to have a preference, or there was a preference towards surgical intervention, but that subsequently shifted more towards strength and conditioning physiotherapy. So could you just elaborate on that for us?
Obviously there are some conditions that just you need to have a surgical intervention. What I was trying to say is that most shoulder injuries are due to the change in kinetics and strength of the shoulder joint. It's such an unstable joint, and it's really held in place by the muscles, as Ben was saying, working together to produce a stable joint. So most shoulder injuries can be cured and helped by the correct strength and conditioning work and the strength and the correct physical therapy. And I think that goes on to explaining why we've worked with strength and conditioning coaches and physiotherapists on slap lesions in athletes. And we found that we can actually stabilize the joint because the joint is obviously less stable with a glenoid that's torn away, but we can stabilize that joint by increasing the strength and the coordination using a lot of the techniques that Ben and Gus have shown us this evening. And using those, and because of the advancement in those types of technique, we found that absolutely top-end elite athletes can cope perfectly well with a slap injury in their shoulders.
Brilliant. Thanks, Mike. We'll just move on to Gus. There was a couple of questions that came through regarding good apps for measuring range of motion. Is there any that you can recommend for us, Gus?
The one I used in those videos is literally just called Angle. That it's free. There's loads of them. I haven't played around with enough of them to know which one's best, but that one does a perfectly fine job.
Okay. And I think there was a lot of interest around the discussion of transfer of force. Could you just give us a bit more of a detailed overview of the landmine rotation test in terms of how you load? You mentioned using incremental loads, what you would do there, and how you would track the velocity of the bar, and any particular markers you'd be looking to use there in terms of normal flow test.
Yeah. So in terms of the test itself, you just need a landmine attachment for the bar. In the video, I think this is recorded, so you'll be able to watch it back, but the video, you stand side on to the bar, so you rotate through as you throw it. And the instruction to the athlete is similar to what Ben was saying. It's as fast and as hard as they can throw it. So you've got to back yourself to catch the bar. When you add load to something, no matter what the task is, if it's a jump or a throw, the heavier it goes, the slower the bar will move. So you form, essentially, by doing incremental increases in load, you'll form a power curve, and then you'll be able to find the optimum weight and velocity for that athlete to train at, as well as identify any deficits in that curve. To measure it, we use Muscle Lab, an encoder similar to GymAware, which is basically a piece of string that's pulled through a machine. It's attached to the bar with a clip. It's pulled through a machine that registers the velocity of the bar, and we just tell the computer how heavy it is, and it will calculate force in watts, and then you can apply that to watts per kilo. As for normative data, we simply haven't done enough testing on it to be able to give any like decent information on that, because the variability. Last week I tested 2 people, one was 55 kilos, one was 95 kilos, so there's no mid ground there of what's normal.
Cool. Brilliant, thanks Gus. This one's directed at anybody that wants to take it, and feel free to jump in. There was some discussion in the chat around, obviously, what we've covered is mainly towards objective markers. Is there anything in terms of psychosocial factors that you guys would suggest, either towards management or measurement?
Very quickly, I'll just say we use the shoulder injury return to sport index and the DASH, so disabilities of arm, shoulder and hand. I'll quickly say that the DASH, if you're working with anyone who's athletic, will be a very low ceiling. They'll max out the test very early in their rehab. So the shoulder injury RSI or CERSI would be a more sensitive test from my perspective.
Cool. Anything to add, guys?
It's from a psychosocial point of view, certainly with the elite athletes, we regularly monitor their sleep, how they're feeling about the difficulty of the sessions, whether they're getting muscle fatigue and muscle tiredness following the session. And those things add together to give us a picture of how they are performing mentally as well as physically.
Cool, thanks Mike. Ben, moving on to you. You mentioned in your presentation, and there's a lot of S&C coaches and physios on the call, and the question always comes around to how strong is strong. And we talk about in a back squat of 2 times body weight, for example, but obviously in the ASH test, much less data available. And I know you gave an example in rugby. So across some of the different sports that you've worked with, is there anything that you would define strong or weak subsequently?
Yeah, it's a question I get asked a lot, and with all the data that's coming in from this now, it's actually difficult to keep on top of. But I would say that probably the best advice is to start with a kind of pass mark of around 1.6 to 1.7 newtons per kilogram, and that applied to the UFC fighters in Shanghai, that applied to the Chinese Olympic swimmers, that applied to the original Saracens paper. But of course there are outliers, so you can go up to 2.6, 2.7 newtons per kilogram. So some of the highest forces produced in the ASH test are around 270 newtons. But it's still about the relative value. So if you have some pre-injury data and seeing what percentage of someone's at when they're coming back, that's a really useful marker, I think, as well. Yeah, and there's another question I actually saw when I went through there around why it's in newtons on force platforms and not Newton meters. I think one of the considerations we're looking into a lot is this lever length. So actually calculating arm length and then looking at the torques and the relative torques that we're producing in those longer lever positions may differentiate your sort of long versus short lever athletes as well. And I think that's a useful addition.
Cool. We've probably got time for 2 more questions. Just another one for you, Ben, as well, and then we'll do one generically at everybody. Obviously, you spoke a lot about the rate of force development during your test. Rate of force development can sometimes, particularly in lower limb testing, be a difficult metric to get reliable. And obviously, if you want to monitor over time, then that's something we need to consider. any tips from your experience to help clinicians, coaches, to get good, useful data in the clinic or on the gym floor?
Yeah, that was a question. That's a great question, and that's a question I had when I was looking into RFD. Originally, I'd thought that RFD was, you know, if you built up to a force over 2 seconds, and of course it isn't. It does identify willingness, and I think I spoke to the guru of RFD, Nick Maffioletti, and he'd written a 20-page paper on this, and I'd read through that, so I decided to phone him up, and he said, look, go fast and hard with your coaching. If you want just RFD, do a 1 second test, not a 3 second test. And actually, Dan Howells, when he worked at the Astros, looked at a 1 second test and then a different test for peak force. He used a 3 second to 5 second build up. So I think that's an interesting idea. But if you're going through a whole group of athletes and you want one test, 3 seconds is good enough, but you just have to coach them and educate them about punching their arm through the floor. And that coaching was done really well recently with a group at the Scottish Rugby Union at Edinburgh and Glasgow. And one of the athletes produced 2,000 newtons per second, which is a remarkable rate of force development, you know, in that first early stage of movement. So the coaching is really important. And yes, you're right. There's huge variability around RFD. So you have to get the conditions, the environment, the setup and the coaching right. But once you do, you'll get some decent data.
Cool, fantastic. Okay, and then probably got time for one more, and this can be taken by anybody, or you feel free to chip in. So there was some discussion around return to play markers. I appreciate this will obviously vary based on the sport and a needs analysis and those types of things, but any key tests that you guys have used, you know, you can give a specific sport example if you like, to help you determine readiness to return to play from shoulder injury.
Me and Ben actually had a discussion about this recently. The real difference between throwing sports and combat or collisions. So we looked at, you know, an arc of rotation and the ability to produce force in that arc. So a total range of movement and the handheld test would be really useful markers for a throwing based sport, especially something like baseball where it is all through that arc. And then collision based sports, rugby, obviously you have the Ash test because it correlates so well in terms of the positions, but their willingness to absorb force on landing. So a closed chain test. So either the plyo push up we used here, or there's a closed kinetic chain upper extremity test. So CKQs. We're not quite sure on what it tells us, but one of those two in terms of how much force are you willing to absorb through your shoulder.
Cool. Anyone else want to add anything?
I would just add to that, you know, we haven't gone for the traditional research-based tests. We've taken some of the applied tests that we know have got reliable data, and we've done our own kind of validation on our own reliability on that. And that will build and grow over time. And I think a lot of the times people go back to the literature for tests and they go around this cycle of repeating what's already been done and don't push forward and use some of the things that are being currently used in applied practice. And where we are is certainly trying to, you know, pioneer a new kind of process which incorporates the psychosocial factors, incorporates strength and power and mobility in the best way that we can. But this will evolve, of course, and we'll see sometimes that some of those tests may become redundant further down the road. And that's the sort of world that we live in right now, is just trying to be sharp and on the cutting edge of using the right test to give us the information we need.
Yeah, fair enough. Brilliant. Thanks very much, guys. I think that's a perfect note to finish on. Just a quick thank you to everybody that registered for tonight's webinar, and obviously a big thank you to our expert panel. Please follow us on Twitter. We're at the ICH, and obviously you can find more information about our clinics, our research, and you can obviously view these webinars online at www.ich.co.uk. The next webinar in this series is on March the 18th, and the focus is going to be on the lower limb, looking specifically at ACL injuries. So please check out for updates and details on that. Thank you very much, everybody, and have a great evening.